Picture this. You're walking into exam room 3. It's your clinical rotation, and you're staring down this classic, but just incredibly frustrating presentation.
Oh, I think I know exactly the one you mean.
Right. The owner sitting on the bench looks absolutely exhausted, like serious bags under their eyes.
Because the dog's been waking them up.
Exactly. Reliably at like 4 in the morning just to vomit up a puddle of yellow foam.
Yeah, just that distinct frothy yellow bile.
But then, you look down, and the dog is literally bouncing off the walls, tail wagging, bright-eyed, looking completely healthy.
It's such a jarring disconnect for the client.
It really is. And, usually when we talk about a medical diagnosis, there's an expectation of precision. Like a fractured femur shows up as a jagged white line on an X-ray. It's binary, broken or not broken.
Right, it's visible, it's easily categorizable. And as clinicians, I mean, we really gravitate toward that comfort. We like pointing at a diagnostic panel and confidently identifying the villain.
But then you step into the world of functional gastrointestinal issues, and suddenly that X-ray machine feels completely useless.
Oh, entirely useless in this context, yeah.
We're looking at a diagnostic landscape that is entirely murky. And for you, the veterinary student listening to this deep dive right now, handling this specific scenario is practically a rite of passage.
It really is something you will see constantly in practice.
Which is why today, we have taken your massive stack of veterinary lecture notes, clinical pharmacology texts, a handful of peer-reviewed case studies, and just distilled them down into exactly what you need to know.
That is the mission today. We're unpacking this precise clinical picture, which is bilious vomiting syndrome, or BVS.
Right.
Our goal is to arm you with the physiological why behind that yellow foam, the exact diagnostic roadmap you need to navigate these cases, and, the specific treatment protocols that will help you ace your boards.
And let that poor owner finally get some sleep.
Yes, exactly. That is the ultimate goal.
So, if our working theory here is that we're dealing with a mechanical failure rather than, say, an infectious one, we need to understand the machinery we're working on.
Right.
Who is this bouncing, vomiting patient in front of us? And what exactly is happening inside their GI tract to cause this highly specific presentation?
Well, the signalment gives us our first major clue. You will see this commonly in dogs, but interestingly, it's quite rare in cats.
Oh, wait, really?
Yeah.
Rare in cats?
Yeah, very rare. It's predominantly a canine issue. And within the dog population, you're usually looking at middle-aged or older animals.
Okay, so like a 7 or 8-year-old dog?
Exactly. And there is no specific breed or sex predisposition you need to memorize here. A 12-year-old poodle is just as likely to present with this as an 8-year-old mixed breed.
That tracks. I mean, it's just a widespread canine issue. And the clinical signs are incredibly specific, right? We aren't just talking about a dog who got into the trash and is throwing up partially digested kibble.
No, not at all. The hallmark of bilious vomiting syndrome is chronic intermittent vomiting of only bile.
Just the yellow stuff.
Right. You'll see that yellow, frothy fluid completely devoid of food. And the timing is critical because it's specifically associated with an empty stomach.
Hence the 4 in the morning wake-up call.
Precisely. The signs almost always occur late at night or very early in the morning, right before breakfast. It might happen every single day, but actually more often it presents intermittently.
So maybe a couple of times a week.
Yeah. But the crucial detail for you to note in the history is that between these vomiting episodes, the animal appears completely normal.
Which is why they're bouncing off the walls in the exam room.
Exactly. Even immediately after vomiting, the dog just shakes it off and looks totally healthy.
So something is obviously going wrong in the mechanics of the gut here. I mean, bile belongs further down in the intestines to help digest fats, right?
Yeah, yes, in the duodenum.
So why is it ending up in the stomach just to be thrown up?
Well, the exact definitive cause is technically still unknown in the literature. But we do have a highly probable suspected mechanism.
Okay, what's the theory?
It basically boils down to primary gastric hypomobility or abnormal intestinal peristaltic motility.
So the gut just isn't moving right.
Right. Prolonged fasting or gastric inactivity seems to modify the normal motility patterns of the GI tract, specifically disrupting what we call the migrating motor complex.
Okay, let me visualize this. If the stomach and the intestines are like a factory conveyor belt, right? Normally, food goes on the belt, the motor runs, and everything proceeds in an orderly one-way direction out the factory door.
That's a good way to look at it.
But with BDS, if that stomach conveyor belt is left running on empty for too long during an overnight fast, does the normal forward momentum just stall out?
Yes.
And without that forward push, does the bile further down the line actually slip backward?
That is a perfect mechanical analogy. When the stomach is empty, that forward momentum drops. The pylorus might relax or fail to maintain its usual tone.
It just stays open.
Right. And the result is enterogastric reflux. The bile slips backward from the duodenum into the empty stomach. And because bile acids act as harsh detergents, they essentially strip the gastric mucosal barrier.
Ouch. That sounds painful.
It is. It allows hydrogen ions to back diffuse into the mucosa, causing severe irritation. And the stomach's natural physiological response to that level of irritation is to expel it.
Get it out immediately. So we basically have an idling engine that causes a reverse flow, leading to a chemical irritation.
Yes.
But if we suspect this motility failure, how do we actually prove it in a clinical setting? Because vomiting is a very loud alarm bell for a lot of dangerous differential.
And this is exactly where we run into the diagnosis by exclusion dilemma.
Okay.
You can't just look at this dog, listen to the owner's story, and declare it BVS. You have to arrive at it by systematically proving that it's not anything else.
Because it mimics other stuff.
Oh, it mimics a multitude of other gastrointestinal and non-GI disorders. That altered proximal GI motility we just outlined could actually be secondary to an underlying gastritis or duodenitis or even an intestinal obstructive disease.
Right, like a partial blockage could be the thing causing the conveyor belt to stall rather than just an empty stomach.
Precisely.
Are there any historical red flags we should be listening for during that initial consultation?
Yes. A major risk factor to ask about is any previous surgery involving the pylorus, like a resection.
Oh, yeah.
Because if the animal has had surgery there, the mechanics of that region have been permanently altered, which significantly increases the risk of enterogastric reflux.
That makes sense. Make sure to get a thorough surgical history.
Yeah.
So, moving to the actual workup. We pull blood, we collect urine.
Mm-hmm.
What are we expecting to see on a standard CBC, biochem panel, and urinalysis?
You should expect them to be completely unremarkable.
Completely normal.
Yes, that's actually what you want to see. But, you absolutely cannot stop at blood work. You must run fecal exams.
Fecals too, for vomiting.
Yes. This is a massive clinical trap. Giardia or other parasites can cause clinical signs that perfectly mimic idiopathic bilious vomiting.
Wait, that is terrifying. A dog comes in vomiting bile in the morning, the timing fits perfectly, but it's actually a Giardia infection driving the motility dysfunction.
Exactly, which is why you must rule it out. You also need to investigate inflammatory bowel disease and intestinal neoplasia. Both of those can result in secondary bile reflux.
Okay, so if the blood, urine, and fecals are clean, let's look at imaging. I know a barium contrast study is sometimes discussed for motility. If we use barium, will that definitively show us the stalled conveyor belt?
You have to interpret barium studies with extreme caution here.
Why is that?
Because of the physiological reality of how the gut works. Liquid barium leaves the stomach via first-order kinetics, which is completely different from a solid meal that requires mechanical grinding in the antrum.
So a standard liquid barium swallow might look totally normal.
Completely normal. You would have to use radiopaque markers mixed with food or special motility capsules to test solid phase emptying and actually reveal the delayed gastric emptying.
And even then, a study at noon might not capture the full picture of what happens at 3 a.m. when the animal is in a deep fasting state.
Exactly. The timing is a huge variable.
What about endoscopy? If we scope the dog, what are we looking for?
Endoscopic findings are frequently unremarkable, too.
Really? Even with the scope?
Yeah. However, you might see evidence of bile pooling or mild gastritis, specifically in the antral region of the stomach.
Because that's right next to the pylorus where the bile is refluxing from.
Right. It makes anatomical sense. But the real value of the endoscopy isn't necessarily finding BVS. It's that it helps you definitively rule out structural or inflammatory diseases of the stomach or duodenum.
Okay, I need to play devil's advocate here for a second because I'm putting myself in the shoes of the vet student who has to actually pitch this estimate to a client.
Go for it.
You're telling me to charge this exhausted client for blood work, urinalysis, fecal panels, potentially specialized solid phase barium studies, and maybe even referring them for an endoscopy under general anesthesia. And we are doing all of this with the genuine hope of finding absolutely nothing.
You are, and you must confidently stand behind that recommendation.
Break that down for me. How do you justify a massive workup for basically a bored stomach?
Because when you look at the broader scope of veterinary medicine, a chronically vomiting dog is a potentially deteriorating dog until proven otherwise.
Okay.
Confidently ruling out inflammatory bowel disease, giardia, neoplasia, and physical obstructions is the only medically sound way to arrive at a bilious vomiting syndrome diagnosis.
I see.
You are not charging them to find nothing. You are charging them for the rigorous diagnostic certainty that their dog does not have an aggressive tumor or a swallowed object slowly necrotizing their intestines.
Wow. Put that way, it makes total sense.
Right. Only once those terrifying differentials are off the table can you safely proceed to BVS treatment.
That is a vital shift in perspective for a student moving into clinical practice. A negative test is actually a positive outcome for the patient. So we've run the gauntlet. We ruled out gastritis, IBD, neoplasia, and obstructions. We have officially arrived at bilious vomiting syndrome. How do we treat a disease where the stomach is mechanically stalling out just from being empty?
Well, the brilliant news is that once you've ruled out those insidious diseases, BVS is generally not a serious or debilitating disorder.
That's a relief.
And the first line of defense isn't even a medication, it's purely dietary.
The prescription is literally a meal plan.
Yep. You instruct the owner to feed the animal multiple smaller meals throughout the day, specifically making sure to include a late evening meal.
A midnight snack.
Yes, a midnight snack.
I honestly marvel at how elegant this is. Instead of immediately throwing pills at the problem, we're just manipulating the physiology of the gut. By giving them that late evening kibble, we are forcing the GI tract out of the fasting migrating motor complex and back into a fed state motility pattern.
You are keeping the factory conveyor belt moving.
Breaking the fast before the fast can break the rhythm.
Exactly. By keeping the stomach engaged, the pylorus maintains its proper function and the bile stays where it belongs. And for a large percentage of dogs, this simple dietary modification completely resolves the clinical signs.
That's amazing. The client just holds back a portion of the dog's daily caloric intake and feeds it to them right before turning out the lights. It's simple, it's cheap, and it's highly effective.
It's the ideal first step.
But, biology rarely reads the textbooks.
Very true.
What happens when the midnight snack fails and the dog is still waking them up at 4 a.m. with yellow foam?
If diet modification fails, then you move to medical treatment. And this is where you need to know exactly which drugs to deploy from your pharmacological arsenal, their mechanisms of action, and most importantly, their contraindications.
All right, let's break out the prescription pad. What's our first option?
There are 3 specific classes of medications used symptomatically for BVS. And keep in mind, a positive response to these treatments actually supports your suspected diagnosis.
Okay, good to know.
So the first option is gastric mucosal protection.
To protect the stomach lining from those harsh bile acid detergents we talked about.
Yes. The drug of choice here is sucralfate, which usually comes in 1-gram tablets.
I remember from pharmacology that sucralfate is basically a mucosal Band-Aid. But how is it working mechanically in the stomach? Is it just like neutralizing the bile?
No, it doesn't neutralize. In the acidic environment of the stomach, sucralfate undergoes cross-linking. It polymerizes to form this viscous, sticky paste.
Oh, interesting.
And it selectively binds to the exposed proteins of the ulcerated or irritated mucosa.
Okay, to carry our analogy forward, it's essentially laying down heavy-duty tarps on the factory floor to protect it from the chemical spill.
That's exactly what it's doing.
What are the dosages we need to commit to memory for the tarps?
Okay, for dogs under 20 kilograms, you will prescribe 500 milligrams per dog by mouth every 6 to 8 hours.
Every 6 to 8 hours, got it.
For dogs over 20 kilograms, increase that to 1 to 2 grams per dog by mouth every 6 to 8 hours.
Okay, and what about that rare cat?
If you happen to be treating that exceptionally rare feline case, the dose is 250 milligrams per cat by mouth every 8 to 12 hours.
All right, we have our tarps down. What is the second option?
The second option targets the root of the motility failure. We use a gastric prokinetic agent.
A prokinetic. Okay.
The standard drug here is metoclopramide, which typically comes in a 1 milligram per milliliter liquid concentration or in tablet form.
So if sucralfate lays down the tarps, metoclopramide forces the conveyor belt motor to turn back on.
Exactly.
How does it actually jumpstart the system?
Well, metoclopramide acts primarily as a dopamine antagonist. By blocking dopamine receptors in the GI tract, it sensitizes the tissues to acetylcholine. And that effectively stimulates upper gastrointestinal motility and increases the tone of the lower esophageal sphincter.
It aggressively forces the forward momentum.
Yes, it gets things moving again.
What's the dosage for jump-starting the motor?
For both dogs and cats, it's 0.25 to 0.5 milligrams per kilogram by mouth every 12 hours.
0.25 to 0.5 every 12 hours. Okay, we have our protective tarps and our restarted motor. What is the third approach?
The third option alters the chemical environment of the stomach to minimize further irritation. We use a proton pump inhibitor or PKI.
Oh, like omeprazole?
Exactly. Omeprazole is the go-to drug in this class.
Let's ask you, though, why are we reaching for a proton pump inhibitor instead of, like, a traditional H2 receptor antagonist like famotidine? Is omeprazole just a stronger acid reducer?
It really comes down to the mechanism of action. H2 blockers just block one pathway of acid stimulation.
It's the histamine pathway.
Right. But omeprazole irreversibly binds to the hydrogen-potassium ATPase enzyme system at the secretory surface of the gastric parietal cell.
It goes right to the source and just turns off the acid sprinklers on the ceiling entirely, regardless of what's stimulating them.
Exactly. It's a much more comprehensive block.
What is our dosage for omeprazole?
For dogs, it is 0.5 to 1.5 milligrams per kilogram by mouth every 12 to 24 hours. And for cats, it's 0.75 to 1 milligram per kilogram by mouth every 24 hours.
Okay, I have a logistical question about all of these.
Sure.
You're giving me dosing intervals of every 12 or 24 hours. But the clinical signs, that bile vomiting, it only happens in the early hours of the morning. Are we really asking owners to pill their dog all day long? Especially trying to pill a cat every 8 hours of sucralfate.
That leads to an incredibly important clinical pearl.
Lay it on me.
Because the signs occur at night, heavily associated with the fasting state, a single evening dose of these medications may be the only thing required to prevent the clinical signs.
Oh, wow. That is massive for owner compliance.
That makes a huge difference.
I mean, pilling an animal once before bed is infinitely more manageable than a rigid 3 times a day schedule.
Absolutely.
But I need to pause here. I'm looking at our pharmacological arsenal, and something is flashing red in my brain regarding metoclopramide.
Okay, let's hear it.
During the diagnostic phase, you were adamant that we must exhaustively rule out an intestinal obstruction. Yes.
And now we are talking about metoclopramide, a prokinetic that forcefully pushes the GI tract to move forward by sensitizing it to acetylcholine.
Right.
If we skip the imaging, or if an owner declined the workup and we failed to definitively rule out a partial obstruction, and then we gave this dog a prokinetic, would we be forcing the stomach and intestines to push as violently as possible against a closed door?
You absolutely would, and that is the exact critical thinking you must bring to the clinic floor.
This is a massive risk.
It is. Gastric prokinetic agents are strictly, unequivocally contraindicated for GI obstructions. If there's a foreign body lodged in the duodenum and you force the gut to aggressively contract against it, you can cause an intestinal perforation.
Oh, man.
You will turn a surgical case to a septic, fatal outcome.
That's terrifying.
That is why the thorough diagnosis by exclusion workup is never about padding the bill. It's about ensuring the medication you prescribe does not kill the patient. That perfectly illustrates why skipping steps in the roadmap is dangerous. It's not just about being thorough, it's literally about safety.
Exactly.
Are there any other contraindications for metoclopramide we need to circle in red ink?
Yes, there are a few. Metoclopramide is also contraindicated with concurrent phenothiazine and narcotic administration.
Okay, good to know.
Furthermore, you should never use it in animals with epilepsy.
Wait, why are we avoiding it in epileptics? We're treating the gut, not the brain.
Because metoclopramide crosses the blood-brain barrier.
Oh.
Yeah. As a dopamine antagonist, it alters central neurotransmitters. In some animals, it causes neurologic side effects like severe nervousness, anxiety, or even depression.
Wow, I had no idea.
And in an epileptic animal, altering that neurotransmitter balance can drastically lower their seizure threshold.
So keep metoclopramide far away from obstructions, narcotics, phenothiazines, and epileptics.
Got it.
Let's bring this entire clinical picture together then. The owner institutes the midnight snack or gives the evening dose of omeprazole, and they return for a follow-up. What is the expected outcome?
You should expect a highly relieved client. Most patients respond beautifully to one of these treatments. And like we said earlier, that positive clinical response acts as the ultimate confirmation of your bilious vomiting syndrome diagnosis.
But what if they don't respond? What if the dog is still waking them up at 4 a.m., despite the midnight snack, the sucralfate tarps, and the omeprazole?
A failure to respond strongly suggests that your diagnosis was incorrect or that an underlying causative factor was missed during the initial workup.
So you have to go back to square one.
Yes. You should also keep a briefly associated condition on your radar, which is gastroesophageal reflux. Sometimes the motility dysfunction isn't just isolated to the pylorus, but also involves a failure of the lower esophageal sphincter.
Because it's a continuous connected system.
Exactly.
So, synthesizing this for the vet student heading into exams, you have a middle-aged dog vomiting pure bile early in the morning and looking totally normal the rest of the day. You exhaustively rule out giardia, IBD, neoplasia, and obstructions to ensure you aren't masking a fatal disease.
Right.
Once you're confident the anatomy is clear, you prescribe a late-night snack to break the fasting motility cycle.
Yep, the midnight snack.
And if diet fails, you strategically deploy sucralfate to protect the mucosa, omeprazole to halt acid production, or, provided there is definitively no blockage, metoclopramide to restart the motor, targeting that evening dose for maximum compliance.
That is the complete, comprehensive roadmap for managing BVS.
It is fascinating how a syndrome characterized by such dramatic, sleep-depriving clinical signs can ultimately be managed by simply understanding the mechanical rhythms of an empty stomach.
It's all about the physiology.
Which leaves me with a final thought to mull over and something for you, the listener, to consider the next time you're standing in exam room 3.
What's that?
Well, if something as simple as the idling rhythm of an empty stomach can disrupt the migrating motor complex and cause such distressing clinical signs, what other subtle rhythms of the gut might we be entirely missing?
Oh, that's interesting.
Right. How much of an animal's boundary between health and disease is quietly being dictated by our modern, convenient twice-a-day feeding schedules or their interrupted sleep cycles without us even realizing it?
We disrupt a lot of their natural rhythms.
We really do. We naturally crave the comfort of a definitive lab result or jagged line on an X-ray. But perhaps the true mastery of veterinary medicine lies in learning to read and respect the invisible mechanical rhythms of the body.
That is a profound question to carry with you into the clinics.
Until next time, keep asking the hard questions, trust your process of exclusion, and maybe give your own dog a midnight snack tonight.